You talked about how no one believed in you at the start, and it's just so difficult to believe that. It's one of those pieces of cliched advice that you hear in every story. No one believed in us at the start, and I don't know why. I've heard that a million times, and then when I heard you say it, I still didn't believe it, just seeing how pervasive the stent is now. I mean, right before we started recording, you had shared with us how it's not even countable, like the implications. What are the ballpark figures of the wide-reaching use case of this invention and the cascading inventions that followed it?
Well, so that's what people don't appreciate. When we started, I knew personally that this device, you could put it anywhere in the body and it was going to work. And what you learn is that every body passageway suffers from collapse. And that's why balloons worked good but not great. In fact, when we met the J&J guys, their head engineer was a guy named Mike Schuler, who was a Rutgers guy, I think, and he was probably one of the smartest people I ever met. They put him in charge of marketing and development. And we gave the presentation, and the first time he saw it, he was speechless, and he said, I get it. The body is a series of tubes waiting to be stented. And I said, yes, it is. And he says, no matter where you put this, it's going to work. So I personally had visions that I think it's achieved probably even more than I expected. But the basic concept of a metal sleeve, once you figure out how to make it compatible, and that's what we did, the ripple effect and the other spin-off inventions are extraordinary. So just the coronaries, of course, are absurd. There's at least 2 million people a year, maybe more now, who get stents because they're getting better and better. They're easier to deliver. They come in all sorts of lengths. When we first started doing it, I was the only one in the world who could do it, right? Because I only one who knew how to do it. And it was just this long, and we had one balloon. Now they come in every length you can imagine, every size you can imagine. So now we can tackle every vessel. Back then we couldn't. So just the coronary biz is extraordinary. But then the spin-offs, the whole idea of a TAVR, which is I took one of our stents and I put a valve inside of it. And we crushed it, and then we were going to put it inside the aortic valves. Everybody thought I was crazy. That was the very first TAVRs. But we were so busy because we were working on carotids and renals and iliacs and femorals and coronaries and portocable shunts and aortic aneurysms. We had 10 projects and something had to give. So that's the one that we let pass because we were way ahead of our time. But that's basically a stent. And years later, somebody filed the patents, and now there's probably, I don't know what the number is, probably 500,000, maybe not that many, maybe 300,000 or 400,000 or more, 500,000 TAVRs that are done every year worldwide. Those numbers I gave you, by the way, are probably just the U.S., so double it for the world. So the TAVR, for instance, that is a pulmonary Schatz stent with a valve inside of it. So there's another disorder of abdominal aneurysms, which had always been relegated for open surgery, where the surgeon would open up the belly and then replace the aneurysm. Well, we were the first to do it internally. So that was another one of that's a stent. So you put a stent here and a stent there, you connect it with PTFE. So that's a spin-off, but it's still the basic formula is a balloon expandable stent. And then there are other applications in pediatrics and all that. So to answer your question, I don't even know what the number is, but it's millions. And what happens is the device gets better and better and better. As it gets better and better and easier, then the indications start expanding and you start treating everybody. And probably the most dramatic is the treatment of a heart attack. There are 500,000 deaths every year from heart attacks. And heart attack is where a blood vessel just completely blocks and there's no flow to the heart. So your heart pumps 8 tons of blood a day, 16,000 pounds of blood a day, and it needs food. Food comes from blood, and that blood comes from coronaries, the blood vessels. So think of your heart as a car engine. If Lewis is driving his Ferrari to Los Angeles at 120 miles an hour and someone cuts the fuel line, the engine dies. That's a heart attack. And that's what we don't want to happen. So we try and catch people before that happens, but sometimes we can't. So why that's important is that when I saw my first heart attack patients in the 1970s, the mortality death was 30% in hospital, 30 days. 30% of people, 20 to 30 people would die. There's no treatment. There was no treatment for heart attacks. We didn't even know what really was causing it until the 1970s. And so you would have patients come in, young people too, 50-year-old people, men, women, and they would have a heart attack and suffer horrible hospitalization and eventually die of arrhythmias or heart failure. And we had nothing to do for them. So in the 1970s, some guy in the 60s, they had an idea of doing open heart surgery. And then in the 70s, balloons for opening up blockages. But that 30% number is now 2 to 3%, and that's all because of stents. So a patient comes in, and they used to be in the hospital for 8 weeks. That's how long, that was the treatment for heart attacks. Now a patient comes in with a heart attack, and it takes about 20 minutes, and we go through the wrist here. These pediatric catheters, they're just 2-millimeter catheters. We snake it inside the heart, and within minutes, the vessel's open, their pain goes away, the EKG settles down, and all of a sudden, the color comes back in their face, and they go home the next day. And they're playing golf 2 or 3 days later, and their heart is normal. It's like it never happened. Big difference from the 1960s and 70s when they suffered really a horrible death of heart failure and arrhythmias in the hospital for weeks and weeks and weeks, 30% mortality. So then, and that's all because of how good stents have become and how clever we've become in how to treat them with medications and post-op care and stuff like that. So just one of many, many examples. A lot of the valves we do now are people that could not be operated on because they're too sick. A lot of these patients are 90 years old. You can't do open valve replacement on them because they're not going to make it. The mortality is 60 or 70% if you try and fix somebody. All those people are getting TAVRs now. Those are people that we were very, very happy just to let go. You just tell the family, hey, grandpa's not going to make it. Let's just make him comfortable. Mm-hmm. We actually did a 103-year-old guy a few years ago. My partner did it, and 103, he actually did great. And, I think he lived for several more years, but symptom-free. So that's the ripple effect that you actually mentioned there, Lewis, and you can't even put a number on it. What's amazing is its longevity, and that nothing's replaced the stent. It's been 30 years, and nothing will. Nothing is going to, for as long as I'm going to be around, nothing is going to replace. I don't see anything that's going to replace it. It's just it's too easy. The engineering's so great. The drugs are so great. They're drug coated now. The access is so much better. There'll be incremental improvements, but nothing on the horizon, unless we come actually with a cure for coronary disease, where like when you're a child and you're at risk, they give you a gene or something and you don't get it. So that's Star Wars stuff. But no, I think the stent's here to stay. It's a great legacy, and it certainly exceeded our expectations.